A 41-year-old female presented with pelvic pain, profuse menorrhagia, and severe symptomatic anemia, near syncope and shortness of breath. She underwent total abdominal hysterectomy with bilateral salpingo-oophorectomy, TA/BSO, as the continuous bleeding was not responding to conservative measures and the patient had no further desire of fertility. Biopsy showed an infiltrate in the endomyometrium, fallopian tubes, and cervix of mature-appearing plasma cells that stained positive for CD56, CD38, CD79A, and MUM1 with lambda light chain restriction, consistent with plasmacytosis. Bone marrow, BM, biopsy demonstrated a hypercellular marrow and atypical plasmacytosis, 25%, with lambda restriction. BM flow cytometry was positive for CD38, CD138, and CD19 and negative for CD56, CD20, and CD45 consistent with plasma cell neoplasm. FISH showed 46, XX, female karyotype, positive for 3 copies of 1q21 including CKS1B gene. Free kappa and lambda light chain levels in urine were 39.9, reference range 1.35-24.19, and 1.59, 0.24-6.66, with a kappa/lambda ratio of 25.09, 2.04-10.37. Free kappa and lambda light chains in serum were 12.6, 3.3-19.4, and 16.5, 5.7, 26.3, with a kappa/lambda ratio of 0.76, 0.26, 1.65. No M protein was detected in the SPEP or UPEP. The albumin level was 3.6, beta-2 microglobulin was 1.347 mg/L, and LDH was 163. The patient was diagnosed with non-secretory multiple myeloma with extramedullary plasmacytoma, ISS stage I. Around the time of TA/BSO, the patient also reported progressively painful swelling on the left side of her neck accompanied with odynophagia, dysphagia, and hoarseness. CT of neck showed a left thyroid mass, 7 × 5 × 7 cm, with irregular borders and a multinodular thyroid enlargement. Figure 1, A. Diagnostic incision biopsy demonstrated a very friable, irregular, malignant-appearing mass in the left lobe. A portion of the mass was removed and sent for analysis. Biopsy confirmed lambda-restricted plasma cell neoplasm involving the strap muscles, Figure 1, B. The neoplastic plasma cells were positive for CD138, CD79A, CD45, DIM, MUM1, VS38C, and CD56. The patient remained clinically and biochemically euthyroid. Whole body FDG PET scan showed FDG uptake in a 4.4 × 4.7 cm mass with central necrosis within the left thyroid lobe, Figure 1, C, along with mild FDG uptake within 2 right breast nodules. Figure 2, A. Breast U/S and mammography confirmed the nodules on the PET scan and showed other multiple bilateral nodules. Excision biopsy of the right breast nodule also showed lambda-restricted plasma cell neoplasm, Figure 2, B, and 2, C, positive for CD56, CD138, CD79A, and VS38C. The patient also started complaining of lower extremity bone pain, but skeletal survey was negative. The patient was started on bortezomib, Velcade, cyclophosphamide, and dexamethasone, VCD. After the first cycle, lenalidomide, Revlimid, was added to the regimen, RVCD. The patient completed a total of 1 cycle of VCD and 4 cycles of RVCD. Follow-up PET-CT scan done 6 weeks after the 5th cycle showed no evidence of active lesions. The patient had a clinical complete response, CR, so she proceeded with autologous stem cell transplantation, ASCT, 8 weeks after the 5th cycle of chemotherapy with high-dose melphalan conditioning. The patient tolerated the treatment well. She will be continued indefinitely on daily lenalidomide and alternate weekly bortezomib maintenance therapy and will be followed up with PET-CT scans.